to Specimen Not Found, the podcast that explores the life and careers of clinical laboratory professionals and discusses issues that can help inform other members of the healthcare team and the public about what makes clinical laboratory science such a critical profession within the healthcare realm. I am your host, Drew Jones.
Dana Bostic.
And Letycia Nunez-Argote. This time I want to start talking about a little bit of our experience. And I don't know about you guys, but before I knew about the clinical lab science profession, I really didn't have any notion or concept of what a lab was or what people did there. I don't know what you guys think.
Well, I mean, I'm in the same boat because on the patient side of it, prior to becoming a CLS professional, I had no clue what the lab was, what it did. When the doctor would say, we need to draw labs, I was just like, okay. And then when he would say, the lab work would come back, same thing where I'm like, okay. I didn't understand the relativeness of that or how they were even related at all. And not even realizing that there was a team of professionals with specialized training and expertise performing this work.
Yeah, I would agree. I was kind of in the same boat. I am, however, an offspring of a medical laboratory scientist. However, as a child, I often got ear infections or strep throat, and I just assumed it was the doctors or nurses doing the testing on it like I would see on the television. I've later come to find out how very wrong I was about that assumption. But yeah, I, just like you, had no idea where and who.
Yeah, and the media does that sometimes. It doesn't really show what the reality is. And so I think that it would be kind of cool to talk about that.
Absolutely. And so in our last episode, we gave a short preview of what clinical laboratory science is and some academic opportunities that are available within this dynamic field. Today, we are actually going to view this as the first part of our series, sharing some of our insights into various specialties of the clinical laboratory. So before we start, we want to let you know that every clinical laboratory is slightly different and that the internal organization of a lab is fluid depending on workflow, test volume, and the personnel trained in the different areas of the lab. And so for myself, as an example, I've worked in various areas of the lab. I've worked in large laboratories. I've worked in small settings. I've worked in areas such as chemistry, flow cytometry, and the blood bank. What have your experiences been in working in different labs?
I came right out of school and was offered a day micro job and never left. So I kind of regret that, to be honest. Most of my chemistry and hematology is getting fuzzy nowadays, but I am a lifelong academic medical center microbiologist.
Okay.
Yeah, and that experience does make a difference. When I came out of school, I actually took a generalist position because I wanted to take the time to spend in different areas to decide which one I liked the most. I've worked in a medium-sized hospital. It was not actually very big, very specialized, but then I actually went to a smaller hospital when I worked in Mexico, and there was a difference in that. And so in the big lab, like the one here at KU Health System, there can be multiple samples that go to multiple places. Mm-hmm. So we're going to follow an imaginary set of samples from a patient who we shall call Casey Perez, or we'll refer to him as CP, who is a 63-year-old male with no medical history available in our system. And that happens quite a bit. Some people walk into the emergency room and we've never seen them before. Right. And so we don't have any data on them to kind of guide us. And so we got to start from somewhere. So what happens with Casey is that we're going to be getting some lab test workup for him. So the clinical care team is going to be making some orders, and that goes in the computer. Now, usually when this happens, this will be acute to a phlebotomist who is a specialist that acquired blood samples to come and meet CP to get some blood.
Now, have either of you ever done your own phlebotomy? Because I know here at a large academic medical center, we have a full phlebotomy team. It's made up of like 5 to maybe a dozen individuals who go out on the floor and collect these. But I know some of the smaller facilities, you have to do your own collection. Have either of you ladies had to do that?
Yeah, I actually had the rare opportunity within my role at a pharmaceutical company where we had research studies going on and we had research participants that we actually retrieved blood samples from, and it was our responsibility as a clinical laboratory scientist to draw those specimens. And so it was a skill set I haven't had to use in a good number of years, probably since my undergraduate training, but it was great to dust those skills off, use them again, and I didn't realize how valuable that skill set would be later on in my career.
Yeah, I actually was similar. My first job had a great team of phlebotomists, and it was not, I actually picked the job for that because I was kind of scared of having patient contact. But I have to go to a different facility, and I worked in a blood bank in Mexico, and the way they have it set up is the blood banker collects the sample, tests the sample, and then actually collects the blood donation from the donor. So all of that would happen, and I would have to know all of those skills. But I am happy to say that most of the time, you will encounter a phlebotomist that's professionally trained people, either one of us or a certified phlebotomist. And so in the case of CP, this phlebotomist, our colleague, comes in and they're going to be drawing a whole rainbow of blood tubes. And after that, once the blood is collected, these are going to be properly labeled with CP's name and other identifiers so that they can be sent to the clinical laboratory. And this label is very important because after the blood is out of the body, the only way we can tell that this is CP's blood is because it's labeled with their name, right?
Absolutely. And so one of the samples, which was collected in a gold top tube, is placed in a large centrifuge. And just like the spin cycle of your washing machine, this is how a centrifuge works, where it spins the blood tubes really fast. But in this case, we wanted to separate out the liquid portion of the blood, basically separating the cells from the serum or plasma. And so when CP sample comes out of the centrifuge, it has a dark red layer at the bottom, which is comprised of those red blood cells, and a yellow and clear liquid layer on the top. And so this sample will be sent to the clinical chemistry area, which serves as the front line in laboratory testing. Typically, you'll see chemistry and hematology together as the core lab, because that's where we get that initial data to start figuring out, okay, what is going on with this patient. And so on the chemistry bench, a laboratory scientist will use complex instruments or instrumentation to measure the different chemicals or analytes that are present in CP serum. So this includes carbohydrates such as blood glucose, which some of your family members may refer to as sugar, proteins, electrolytes like sodium and potassium, enzymes, lipids such as cholesterol or triglycerides, drugs, and many other medications or analytes that can be tested.
Yeah, I know the chemistry area and the hematology area are usually the largest, but even the first time I walked in the KU Health System core lab, I was astounded. It looked like a spaceship. Everything was super large and lots of samples were being processed.
Exactly. At these larger facilities, you may see chemistry analyzers doing anywhere from 1,000 to 5,000 tests a day, and you don't need that capability at a smaller facility. So you'll of course have smaller analyzers or even kits.
Right. And with me coming from a large medical institution, straight out of school, I started in a large chemistry lab. And so I had to quickly learn and I guess become acclimated to performing and overseeing that high number of tests that we would perform. And a part of that responsibility as a clinical chemistry technologist was using reference ranges for reviewing those analyte levels. And so with that, the scientist does compare laboratory results, just as in the case of CP. They're comparing these results to see if they are normal using those reference ranges, which with normal results, this would be expected in a healthy person versus abnormal results that can be either higher or lower than the results expected in a healthy person. So that established reference range, if it is abnormal, it could be outside of that range being high or below that range being low. And the reference ranges are used in pretty much all laboratory tests, and laboratory scientists are experts in making sure that the reference ranges are accurate. And so when the clinical chemistry scientist tests CP's blood, she discovers that his chemistry levels are not within normal range. His blood glucose is too high, and his proteins were also abnormal. She quickly reports all of these findings to the clinician. So what are we thinking so far, just based on what we're seeing?
Kind of sounds like diabetes, possibly.
Yeah, the age and the chemistry may be pointing in that direction. And he wasn't feeling very well, came through the emergency room.
Right.
Absolutely.
But there's still plenty of testing we need to go after.
Yeah.
So, CP samples have been tested in the chemistry lab, but now we're taking a different colored top tube, the purple or fuchsia top, and taking it immediately to hematology. Also, we're going to bring along our light blue top and examine it for coagulation. Now, coagulation testing looks at the ability of a patient's blood to actually clot. So what we do is we spin down the tube like we did in the chemistry lab and take the liquid part of that sample off and actually test how long it takes for that sample to clot. We put this up against a reference range, and that's allowing us to know, will the patient clot if, are they at a risk of abnormal bleeding? So we run CP's blood, and it looks like their results are abnormal. His clotting is too slow, and he's going to be at a risk of bleeding if he's to go under some sort of surgical procedure.
Well, wait, Drew, I have a question. So, and this might be in some other of the listeners' minds. So you're saying you're taking the liquid part from the blue tube, which is also the liquid part from that gold top tube that Dana was talking about. Why is that different?
So that's a great question. The gold top tube or the fuchsia tube or the blue tube, each tube has its own special additive in it that somehow works with the blood components and presents them in a way specifically for the testing that we're going to do on it. So what we use for coag won't necessarily work on the chemistry line and vice versa.
And then you have some additives that are designed to prevent clot formation, whereas you have others that will initiate that clot formation because we want the serum or the plasma portion for testing.
So when our phlebotomists are taking a rainbow of blood, it just is because of that reason that different tubes go to different places.
Right. We're not just trying to make you lightheaded.
Right. Not the goal.
Not the goal. So now that we've done the coagulation part of our hematology adventure, we have to look at the other part of the hematology bench. We've taken a different top, and that was our purple fuchsia top. Typically, this is done on a large analyzer that uses a Coulter-based technology and looks at the different types of blood cells found in the sample. For our abnormal patients, oftentimes these get flagged, and we, as the MLS, actually read these ourselves on the microscope. We'll look at CP's sample, and we're seeing, comparing it to the reference numbers, that there's some problems going on. He's got abnormally high amounts of white cells, and these are the cells involved in fighting bacterial, fungal, and viral infections, and abnormally low level of platelets. And these are the cells that are in our bloodstream that help stop bleeding and repair tissue. So we can see here, not only does he have clotting issues, but he also has very low platelets. So this should be a big red flag for us as well. Furthermore, we see that CP has critically low amounts of hemoglobin, and hemoglobin is the part of our red cell that actually binds oxygen and distributes it around the body. And without oxygen, our basic bodily functions do not work. So you can see why low hemoglobin can be a large issue. And this puts him at danger of respiratory distress. So this is something that our laboratory scientists will immediately communicate to the physician or the general healthcare team. So as you can see, things are not looking too good for our friend CP here. What will we do next?
Well, next, really, we haven't explored all the areas of the lab yet.
You're
Yeah,
right.
and it could be a lot of things. You just mentioned white blood cells. That could be an infection, but we also talked about diabetes. It could be, because of those chemistry results.
It could be septic even. Who knows?
Who knows?
There's no telling what can happen next with this patient. So in this episode, we talked about the lab areas of phlebotomy, clinical chemistry, coagulation, and hematology. To find out the rest of this patient tale about CP, tune in for the next part in our series. In the meantime, we hope you will connect with us. You can find us on Facebook at KUMC CLS Program or visit us at cls.kumc.edu. And don't forget to share this podcast with all of your friends. For now, this has been the Specimen Not Found podcast. I am Dana Bostic.
I'm Drew Jones.
And I'm Letycia Nunez-Argote.